of you who have not participated, you might consider talking to your neighbor about the pros and cons to that.
There?
Thank you.
Ready? Okay, we're in a panel discussion right now. This is Paul Lang. I'm monitoring the session. Dr. Schellhammer, Dr. Montgomery, Dr. Schweizer are on the table here, and we've got our audience asking questions. Any questions? Okay, one question. Is Firmagon more effective than Luperon? Snuffy will give you
black and white comparison.
Okay, anybody on the panel want to jump in on that?
Dr. Schweizer, are you're a testosterone man, so if you think making testosterone as low as possible, as long as possible, or at least low as possible for a period of time is what we should do, and you're a Firmagon advocate or not?
So, I mean, I think clearly lowering testosterone levels is effective at the initial stages of advanced prostate cancer, and that's our standard approach, and I think there's no reason to think that we should deviate from that right now. Regarding the issue of Firmagon versus other LHRH analogs, I mean, I tend to agree with Dr. Myers. I don't think there's any compelling evidence that, Firmagon is clearly better than the drug like Lupron. I think for certain individuals it makes sense. If you have somebody that needs to get their testosterone rapidly reduced, if they have a lot of cancer and you really want to try to get things under control quickly, I think you could probably make an argument for using a drug like Firmagon. Otherwise, I still tend to use the older drugs. They're much less expensive, and I don't see any compelling reason to move away from them quite yet.
You might explain what it is?
Yeah, so most of the hormonal therapies really act by, they act on this signaling pathway from your pituitary gland to your testicles, and basically that signal tells the testicles to make testosterone. And the way these drugs work is they interfere with that pathway. The way that drugs like Lupron work is that they promote that signal, they sort of flood it, and after a period of time, by sort of flooding that signal, the pituitary gland shuts off the message. Firmagon works a little differently. It actually inhibits the message from happening right off the bat. So the difference is that when you treat someone with Firmagon, you see that the testosterone levels plummet pretty rapidly, whereas with drugs like Lupron, it takes a little time for them to start working, and you can see the testosterone sort of bump up transiently before it drops again. So that's sort of the difference. At the end of the day, after a month or so, the end result is the testosterone levels probably in the same ballpark regardless of which agent you choose. The question is how quickly do you get it there, I think.
Dr. Schellhammer, you had some comments in your presentation about this issue. Would you have any further ones?
Well, I think I agree with what's been stated, that the testosterone drops more abruptly in patients with more advanced disease burden. That's an advantage, and I think in the issue of so-called flare, which really has never been clearly defined as clinically important, but nevertheless, I would rather see the testosterone drop rather than rise before a drop. And the cardiovascular issue, I think, holds water as well, that there has been clearly a diminution of cardiovascular toxicity with the antagonist, Firmagon, versus the agonist, Lupron, Eligard, and others. The difficulty with Firmagon is it's a monthly injection. It does cause skin irritation and rash and discomfort, so it's very difficult to continue beyond 3 to 6 months, both from convenience standpoint and the skin reactions.
Snuffy, I don't know if you heard Dr. Schweitzer's presentation on BAT. He's one of Desme's fellows, and we've had a discussion about high-dose testosterone. Would you like to jump in and give us your opinion about this somewhat heretical, or at least new approach?
Well, you and I talked about this at ASCO GU. High-dose testosterone was first tried at Memorial Sloan Kettering in 1982, and they saw definitely a group of patients that benefited. And over the years, I've done it, and certainly there are a group of people with advanced disease who've failed standard hormonal therapy who really can have a response to high-dose testosterone. But I don't mean a testosterone of 600 to 800. I mean a testosterone above 1,500. I've seen PSAs drop, bone pain disappear. The problem is there are a portion of patients who accelerate, so it's hard to know ahead of time who will benefit and who won't. So I sort of put it on the back burner until we had a molecular test that could tell us who was going to respond and who was not going to respond. But it definitely works.
Okay, a related question.
And you have a real happy patient too, I got to tell you.
Yeah, I know. I've tried it, and although I don't want to put him back on it, he's just wants to do it. Doctor. Oh, yes.
Yeah, and if a patient takes a sequence of bipolar therapy and the PSA is in an undetectable level, after a number of sequences, would it be advisable to establish a continuous physiologic level of testosterone and go off the intermittent pulsing onto a physiologic level?
That's right.
Well, of course, the old theory of intermittent hormonal therapy was based on getting that testosterone back up. And the way we used to do intermittent hormonal therapy with LHRH agonists, recovery is slow, incomplete, and after each cycle, that would be the testosterone would be recovery would be incomplete. What I've seen with intermittent therapy with Permagon is testosterone recovery is extremely rapid and very complete. And so it's probably a better agent if you're going to do true intermittent hormonal therapy. But the idea of when they go off of suppression, bringing testosterone immediately up to a very high level is an attractive idea. And I've certainly seen individual patients do well. It's just, without a clinical trial, I don't know who's going to benefit and who isn't. But there are definitely people who would benefit from that.
But so I guess when you think about using testosterone as a way to actually treat prostate cancer and sort of applying this concept of, using it intermittently, so bipolar androgen therapy is what we've called it. But when you use it to treat castrate-resistant prostate cancer, the only way we've studied it so far is using it sort of in this monthly cycling. So I guess the short answer is we don't know if, doing that for a period of time and then stopping and maintaining some physiologic level of testosterone would be beneficial or not. We don't even know if 1 month injections is really ideal. One question that I have is maybe men would respond just as well if we rose the testosterone to a high level and just let it cruise, monitor them closely. If the PSA starts to rise, let it fall again. I think there's a lot of different ways to do it, and right now we're really trying to tease out some of the biology behind why it works for some men and not others in some of these ongoing clinical trials I spoke about. We hope to develop some biomarkers that are going to let us sort of monitor the disease and make some determination about sort of who goes on study and when do we administer testosterone versus not, but there's a lot of work to do, and I think that, clearly these studies need to happen.
I guess here in the West, we shouldn't end this subject without at least mentioning Nick Bukowski, who actually started this whole idea of intermittent therapy and bringing testosterone back, and spent his career in British Columbia and recently passed away from prostate cancer. And I hope someday we will be able to finally prove whether he's right or not. One other question about BAT, which was written down, was, Dr. Schweizer, what did you consider long-term ADT when you were talking about maybe using it in BAT? What's long-term to you?
So, the way we defined it in the study was guys that had progressed on to have castration-resistant prostate cancer. So these are guys that have evidence that the disease is progressing in spite of drugs like Lupron. And the idea was that you're probably enriching for a patient population that does have high levels of the androgen receptor. I think ultimately what we'd like to do, though, is take patient samples and look at them and decide, is the androgen receptor higher than you'd normally expect? because those are the ones that we would guess would probably respond to testosterone therapy based on sort of the preclinical models we have in the laboratory. I think there are other candidate markers that we're trying to explore to see if they can predict for the usefulness of testosterone therapy. But there's a lot more work that needs to be done, and I think that really developing sort of patient-specific markers that we can rely on to predict who's going to respond to therapy is the goal. And I know Dr. Montgomery talked a lot about it in the context of DNA repair genes, but I think that there's the flip side of it, that there's this whole androgen receptor signaling pathway, and there's a lot of things that can go wrong with that, and we need to understand the events that go wrong, and if those events are things that would predispose those patients to responding to testosterone.
Yes, there's a question from the audience here.
Yeah. We learned that the initial testosterone level is high, then this androgen treatment, androgen deprivation treatment kind of get resistant earlier. So is this initial testosterone level can affect this bipolar androgen therapy too?
You know, we don't know. I think it's the initial testosterone level may predict for the time to becoming castrate resistant. We've only really looked closely at using testosterone in men that have already reached that point. So whether or not going back in time and seeing what the testosterone level was before they embarked down that whole process of being treated with drugs like Lupron and eventually going on to second-line agents, it's not clear right now.
So you haven't observed any difference between this responder group and not responder group for this bipolar androgen therapy?
We haven't looked at that. I mean, we can certainly see if we can go back and look at their charts and figure that out. I know a lot of clinicians don't necessarily check baseline testosterone before starting on drugs like Lupron, so I don't know if we'll be able to answer that question. But it's interesting. It may very well pan out that is something that's useful to know and may help to predict. But
Snuffy, what do you have any opinion on initial testosterone levels and responses to therapy?
I guess we're really an outlier in that we always measure both testosterone and dihydrotestosterone before we start and every month thereafter. And it's very clear that if the serum testosterone is under 400, when you start hormonal therapy, the odds of a response are markedly diminished. This is part of the reason we've been doing this since the 90s, and that's part of the reason I got into high-dose testosterone. And relevant to the questions we asked earlier is it's a real problem trying to start hormonal therapy with a testosterone under 400, and under 300 it gets to be very difficult with the older drugs. That's where today I would use Firmagon and Xtandi because they're already partially resistant. I would have to say no, just thinking about the way the conversation's gone, this is a very variable disease. And the larger things we've been talking about are for sort of intermediate aggression metastatic disease. But for the lethal phenotype, the very aggressive, rapidly growing metastatic patients, you need to get that testosterone down as quickly as possible, and you need to get them in complete remission quickly, or they're going to get resistant. Manuel Artanarkis' work on the AR7 fragment is relevant to these patients. But that's a very distinct subset that's different than the people you do intermittent hormonal therapy on.
We have a question on the charter trial, and I'll start with you, Snuffy, since you expressed, I think, or implied a opinion. And the question is, when would you begin the Lupron Taxotere therapy? Only when they have high burden metastatic disease, as the charter trial started, or would you now extrapolate it and start earlier? And then I'd like to ask members of the panel if they have any strong opinions on that issue.
Well, I certainly think that the subgroup that benefited in the charter trial, bulky metastatic disease, they'll either need Lupron alone is a complete failure and should never be considered in that patients, and certainly Lupron and Taxotere is a reasonable option. I would have to say the real question in my mind is whether the new anti-androgens might be equally effective. I've seen equally dramatic responses to Xtandi-based programs. And as I said, they have 20% complete remissions in people with metastatic disease who failed Lupron and Casodex. So for people who have aggressive disease that isn't bulky, I lean, although I think Taxotere would be very effective, I lean towards using Xtandi or Zytiga in combination with Firmagon for the people with extensive but not bulky disease.
Okay.
There's still enough disease. You need to get that remission quickly, but I don't think you need Taxotere.
Okay, well, go down.
Nevertheless, if you had to ask me my best bet, what is the best bet for a combination treatment to get a durable, complete remission in advanced disease? It would be Lupron or Firmagon, Xtandi, and Taxotere, and with Xofigo also looking very promising. So I think we're in an awkward period right now where we have the individual pieces of what might come together to be as effective for prostate cancer as it is for cancer of the testes, but we don't know exactly how the pieces fit.
Okay, let's run down the panel quickly. Your opinions on do we extrapolate on Charter or not? Dr. Montgomery.
So I think what we've heard a lot about is the idea of combination therapy and different mechanisms of action. I think one of the attractive aspects of docetaxel is that it works in a different way. So the data from Charted clearly shows that it benefits that subgroup of patients. The data does not support doing it outside of that setting. Many people have been talking about using chemotherapy earlier. We've taken it to the point of running a randomized study of chemotherapy after prostatectomy for patients with high-risk disease. We don't have the results from that study. I can tell you from knowing what the safety data is that people run the risk of even fatal complications if it's not done in a way that is appropriate. So unless we have data to support it, I would never do it outside of that context.
I think it's worth noting that the UK and Switzerland have an interesting trial under the moniker Stampede that is looking at a lot of these combinations in hormone-naive and castrate-recurrent or castrate-resistant prostate cancer. So in the next 2 or 3 years, whether we should be using chemotherapy and the traditional LHRH agonists or antagonists and enzalutamide in combination will come to fore. So the information, I think, is on the horizon in appropriately done trials.
Yeah, I mean, I tend to agree with everything that's been said, more or less. Right now, I use chemotherapy for basically men that have high volume disease based on their scans when they initially present. So, the way that the clinical trial defined it was within 120 days of starting on drugs like Lupron or Degarelix. So that tends to be when I would reserve docetaxel for. And just as a pitch, I think that conceptually it does make a lot of sense to use some of these really potent androgen signaling targeted therapies early on, because it may be that it's just a matter of more aggressive therapy early, and whether that aggressive therapy means Lupron plus docetaxel chemotherapy or it's Lupron plus one of those agents. I think that there's conceptually a good rationale for doing it. And we do have a clinical trial open now that's looking at an experimental agent targeting sort of that androgen receptor signaling pathway more effectively early on, similar to how you would treat a guy who presents that you might consider chemotherapy for. So hopefully that trial will give us some answers about whether or not that strategy really does pan out to improved outcomes for people.
Okay, one more question from the written things. Snuffy, what's your opinions on immunotherapy, and more specifically, one question was on the Duke immune therapy approach using genetic engineered poliovirus. Can you give us your general and specific comments, please?
Well, the Duke program in brain tumor research is one of the best in the country. And I think that it's very promising early results, but I think the cart's gotten before the horse. So they don't even have randomized controlled trials. And while they're thinking of doing prostate, there isn't a lot of prostate data. So there are many promising immunotherapeutic approaches. And I do believe immunotherapy has an important role to play. it's not clear to me at all how that fits into the current practice. So it's one of the hottest things on the table, but I'm not clear how it works out on a day-by-day basis.
Dr. Schellhammer, you have...
Provenge is the only thing we really have right now that's FDA approved for immunotherapy of prostate.
Dr. Schellhammer, you know a bit about Provenge, both in substance and spirit. So what are your thoughts on immunotherapy, Provenge, et cetera?
Well, we have a clinical trial that demonstrated a survival benefit with a time benefit similar to enzalutamide and abiraterone that says in the 4 to 5 month interval of survival with very low toxicity, and which appears, although it's observational and not proven as tightly as it would be in a absolute randomized trial, that the lower the PSA is on institution of immunotherapy, the longer your survival or the greater the benefit compared to the control arm will be. And that makes logical sense. And again, it's borne out in this observational study. So in my opinion, for patients who I see who have asymptomatic or minimally symptomatic castrate-resistant metastatic prostate cancer, I suggest Provenge as their initial therapy, and then understand that we will progress to the other therapies sooner or later.
We had one question from the audience who's been pushing, so go ahead.
Well, my understanding is that testosterone is the breeding ground for prostate cancer cells, if I'm not mistaken. Now, when the PSA is tested, is testosterone a part of that PSA test, blood test? Or why isn't it both are not examined, the testosterone level and the PSA level, or is it part of it?
Snuffy, I'm sure you do both, right? When you see patients, you always get a testosterone with a PSA, or at least intermittently?
Yes, my view is that if you're considering hormonal therapy, you need to know the testosterone beforehand to know if it's too low for the reasons I said earlier. But second, you need to measure testosterone after the administration of an LHRH agonist because in 1 to 5% of cases it fails to suppress testosterone. And several times a year I'll have someone sent to me with a label of hormone resistance, and they weren't hormone resistant, but lupulin had failed to suppress testosterone. Doing hormonal therapy for prostate cancer not measuring testosterone is like driving a car without a odometer, or trying to heat your house without a thermostat. Drugs don't work perfectly, so. And if you're going intermittent hormonal therapy, after you stop hormonal therapy, how are you going to interpret what the testosterone means? I mean, the PSA means if it's rising, if you don't have a testosterone to pair it with. So I think that this should be standard practice.
In the interest of staying relatively on time, I think we'll sort of end it here, and I have to give I have privilege to give a few words sort of riding off into sunset. But Snuffy, since sunset is already starting in Virginia, we'll get you off the hook right now and say thank you for doing this for us. We very much appreciate your time and, most importantly, your great wisdom. Thank you so much.
Thank you very much. Have a nice day. Bye-bye.
I just want to say a few words in closing, and you'll notice that I'm not on the program. That's because in relationship to all these young and very bright people you saw in the IPCR, I'm considered very old. And therefore, they weren't quite sure whether I'd be alive here when it was time. I am very much alive, as is Dr. Schellhammer. And I just wanted to, say I hope this was valuable to you. This is the best audience we've ever had, and every year it gets more exciting, I hope, for you, and certainly for us and for me. I don't have to remind you, but I'm going to, that prostate cancer is not a D recommendation, should be totally ignored. It affects families, and it certainly affected my family, and that's how I got to first learn about and become friends with Dr. Schellhammer, who has become my friend. In fact, we just got back from Antarctica and Galapagos. But it also affects us, and yours truly and Dr. Schellhammer. What I hope we left you with is not only that obvious thing, but also that things are changing. And I think I'm going to cut back on my processed meats and eat more grain and stuff like that, because I definitely want to be around, and I'm sure I will be, when this disease we start using the word cure and control with much more alacrity. And of course, one reason is because, as I've said before, there's this gigantic hole in the line. It's not a few yards at a time. We can sort of see the end zone, if you want to use a football analogy. And of course, one reason is individualized medicine. In addition to the dream team, and we're, I guess, on the Eastern team, because we're part of the East team on Stand Up to Cancer, we are also have launched this Act Smart, which is to make it more prospective instead of retrospective in doing individualized medicine. And you've heard something about that and certainly seen it in the newsletters. And I would like to make one thing, because when we first started this and launched this, and this is not just for Washington or for UW and Fred Hutch, but hopefully for all of, certainly Washington to begin with, that now everybody's got precision medicine on their lips. But it's sort of like someone saying, oh yeah, I know all about cyber wars and cybersecurity. I read the New York Times. Or, no, I work and I'm one of the directors of the NSA. And so there is individualized medicine where you send out blood to some commercial entity, and there's individualized medicine where every day and every month we keep changing and adding and subtracting. And I wish all of you could come to one of the monthly conferences where we actually take patients and look at their genes and try to decide on individual therapies based on what we've learned, what we know from other centers, and also what we learned from animal models. So I hope I leave you with the fact that there is gigantic hope, more so than I think ever before. And you can help us there. By the way, this is on YouTube in case you want to see it again or correct some of our mistakes. We're interested in your thoughts and your ideas. We want feedback for the next one. We'll have another one next year. And we need your support, your emotional support, networking support, and your financial support. We are in one of the top centers in terms of federal funding for prostate cancer, if you can believe the databases. But no major prostate cancer research center can do what they need to do and what they want to do without private support also. And when it comes to private support, I might just mention an event that's coming up. It's the Obliteride Ride. It's not just for prostate cancer, it's for many different cancers. By Fred Hutch, Dr. Nelson will be riding 100 miles again, and the rest of us will limp along and try to at least ride some of that. I might even try 100. So I might even ask you for support, because if the support you give me for 100 doesn't go to cancer research, it'll go to my funeral. So you can't lose. And so with that, I'll just leave you with our many thanks for coming here and for supporting us, and I hope it was worth your time. Thank you.